46-year-old male, middle age, okay, middle age patient with cough and pyrexia. Chest symptoms, okay, cough and pyrexia. With a previous renal transplant. This is very important. This history is very important, okay? It will help you in the diagnosis. So the chest x-ray here showing nodular opasitis. Okay, can you see the nodular opasitis? Okay, and the reticular opasitis. Reticular opasitis. This is called reticulonodular opasitis. Okay, seen in the right upper and the middle lung zones. Okay, so what about the CT scan? Let's see the CT scan. This is the CT scan of the same patient showing, yeah. These nodular opasities seen on chest x-ray is seen here, okay, is seen here along with the reticular opasitis seen on the chest x-ray. The reticular opasitis is seen here as linear branching opasitis. Linear branching opasitis, okay? It's not linear opasitis only, it's also branching, as you can see here, with the centrilobular nodules. Centrilobular nodules, okay? Giving the tree and bud pattern. This is a tree and bud pattern, okay? So here, this is the tree and bud pattern, linear branching with centrilobular nodules. The centrilobular nodules are seen on each side of the linear branching opasitis, okay? Linear branching and centrilobular nodules forming the tree and bud pattern. Tree and bud opasitis, okay? As you can see here, there is all the centrilobular nodules, all of these are centrilobular nodules, okay? These nodular opasitis is seen in the center of the secondary pulmonary lobule, okay? That's why it's centrilobular nodules, okay? The centrilobular nodules is also seen with ground glass opasitis, okay? Can you see the ground glass opasitis? This grayish pattern, grayish opasitis. It's not the same of this lung. It's another, another color. Can you see the difference? This is the ground glass opasitis. So the centrilobular nodules along with the ground glass opasitis seen here, centrilobular nodules and the ground glass opasitis. This is called centrilobular ground glass nodules. Okay, it's a kind of mix. Okay, let's see that here again. Yeah, can you see this one? Ground glass and centrilobular nodules. Ground glass and centrilobular nodules. This is the difference here, seen here. Ground glass, and this is the normal. So the nodular opasities are seen with linear branching opasitis forming the tree and bud pattern, and also seen with ground glass opasitis and forming the centrilobular ground glass nodules. These opasitis are seen mainly in the right upper lobe. These opasitis are seen mainly in the right upper lobe. Okay, are seen mainly in the right upper lobe. However, less marked changes are also seen in the lower lobes. Okay, less marked changes are also seen in the both lower lobes and the left upper lobe. This marked changes as the centrilobular opacity. Can you see the centrilobular opacities here? Okay. However, the tree and bud pattern is mainly seen in the right upper lobe. Okay. There's also something I want to show you. Yeah, this one. There's a calcified granuloma here. Yes, this one. A calcified granuloma is also seen here. This is very important. Calcified granuloma is also seen in the right upper lobe, 3 millimeter calcified granuloma. Uh, Early cardiomegaly is also noted. Okay. Next finding is coronary artery calcification. The coronary arteries arise from the root of the aorta. So this is the root of the aorta. The right coronary artery, yes, that is the right coronary artery, okay, arising from the root of the aorta, and it is seen here calcified. There's calcification of the right coronary artery, okay, and the left coronary artery, after arising from the root of the aorta, it gives the left anterior descending and it's calcified, and the left circumflex coronary artery, and it's also calcified. Next finding is enlarged central pulmonary arteries. This is the normal. The main pulmonary artery diameter normally is less than the ascending aorta diameter. Okay. However, here the main pulmonary artery diameter here is more than the ascending aorta diameter, is equal or even more than the ascending aorta diameter. Next finding is small native kidneys. So as you can see here, the native kidneys are very small. Along with the history of renal transplant, okay, that's why the native kidneys is not functioning and very small. Next finding, calcification of the brachiocephalic vein with chest wall collaterals, which may be due to thrombosis from previous central line insertion related to hemodialysis. So here, this patient has small native kidneys, okay, and has a history of renal transplant. Mostly before the renal transplant, this patient used to have hemodialysis, and for the hemodialysis, he mostly had previous central line insertions for the hemodialysis. And this finding here, chest wall collaterals. Can you see the chest wall collaterals? All of these are collaterals, chest wall collaterals. These collaterals mostly indicate that the patient has or had developed thrombosis on top of the central venous line insertion due to the hemodialysis. So the interpretation here, this patient has chest infection, mostly TB, mostly reactivation of TB, as the patient here is immunosuppressed with the renal transplant. The patient is immunosuppressed here from the renal transplant, so he has developed reactivation of TB. So the diagnosis here, TB reactivation in an immunosuppressed patient, in an immunosuppressed renal transplant patient. The differential diagnosis, other atypical respiratory infection, other chest infections, okay? The management here, this patient needs to be referred to chest clinic for TB investigations and management. So refer this patient for the chest clinic for more investigations for TB infection.